It it was a great idea, and I think Pete really has done a great job with it.
Well, thanks, Pete, for putting it, whoever had the idea and whoever put it together. Thank you very much.
Yeah, it actually started with Johan van Hove's brainchild, and we sort of worked it from there. But that's a good segue. So it's noon Mountain Standard Time, 2 Eastern. I think we can start. It's August 28th, 2020, and I want to welcome everybody to the first discussion with the Medical Biochemical Genetics Fellowship Clinical Core Seminar Series. This is a collaborative effort amongst all MBG programs in the U.S. and program directors to provide a united curriculum for our fellows. It's very clear with the number of folks that signed up for this that it's not just MBG and CBG fellows that have signed up, but a whole lot of other people, which actually speaks, I think, to the desire for everyone in our field to have more knowledge going forward, especially about clinical management and clinical diagnosis and pearls of individual conditions that we deal with on a daily basis. So I'm really happy, again, to see so many people here. I would ask, just as a housekeeping point, a couple housekeeping points, actually. First, everybody looks like they're muted, but just please be respectful and keep all of your Zoom on mute. The format of this meeting is going to be a 75-minute talk, 75-minute plus or minus, by our speakers with a 15-minute Q&A afterwards. I think for the questions, because this is directed towards MBG and CBG fellows, if we could give priority to those fellows, I'd appreciate it. What I would like everyone to do, if you have a question, hold it during the talk, and if you could send it to me directly by chat. If you're an MBG or CBG fellow, if you could put that at the beginning of the question, state your question, and then at the end, I'll call on people if that's okay with everyone. Call your name, read the question, or actually call your name and have you read the question yourself and present it to the presenter, who in this case is Sean McCandless. A couple other things. So today we're doing amino acids part 1. Next week will be Dr. Van Hove doing amino acids part 2. The talk is being recorded and archived, and the details of that are still being worked out. It should be readily available to everybody here. We're working out details with the American College of Medical Genetics to have it housed in their Genetics Academy archives, so it's protected from piracy, from tampering, from anything like that that we would have if we were to store it on YouTube, and it would be more accessible than being stored on our university website, although that would be a second option. We're still looking into it, and we're supposed to be meeting with the board in mid-September for the ACMG to figure out if we can do that or not. So I think without further ado, we can welcome Sean McCandless. He is well known, hopefully, to many of you, past president of SIMD, my boss and section head here at the University of Colorado, and he's going to be talking today about amino acids, amino acidopathies, and urea cycle disorders. So with that, Sean, I'll let you take it.
Great, thanks, Pete. And thanks for the opportunity to be the inaugural lecturer in this series. I think it is a great idea, and I appreciate all your hard work to make it happen. I'm going to jump right in because we got a lot of slides to cover today. If there's any problems with the audio or visual, please let Pete know. Quick thank you to NAMA, from whom I stole some of the slides, many of the slides. So many of you will have done NAMA, and you may recognize some of these. So today we're going to talk about the beginnings of, we're going to start with amino acid metabolism. And just a reminder for you, amino acids are some sort of side chain with a carboxyl group and an amine group on them. So this is the amino acid. The alpha carbon, the first carbon adjacent to the carboxyl group, is the alpha carbon. And so that will come up later. The side chains can be different, can have different types of chemical structures. And as you all know, that's what makes proteins so different, is that the combination of side chains of the amino acid residues in a protein are what determines the tertiary and quaternary structures of the protein that allow proteins to have so many varying functions. In terms of the way your body uses proteins from the diet, it's really as a source of amino acids. And the amino acids that you take in are used to synthesize new protein. And also as proteins in your body are broken down, the free amino acids are released and taken up by the liver or muscle or other tissues to be reused for amino acid synthesis or for protein synthesis. If there's no other way to store amino acids in your body other than protein, so if you have a concentration of an amino acid that's above the value that the set point in your liver, those amino acids will be extracted and broken down for energy. That process is called oxidation, and that's an irreversible process. And then amino acids are also used to make small peptides like hormones or individual chemicals, neurotransmitters, and such. In an adult person, the turnover from proteolysis during the day and protein synthesis is about 300 grams of protein each day. Our food intake is about 70 grams of protein per day, and that's about equivalent of the oxidation or the irreversible degradation of protein that occurs in each of our bodies. And then, of course, there's amino acids are in flux to the various functions that we mentioned above. The degradation or the oxidation of the carbon backbone of proteins in the first, or amino acids, the first step in it, when an amino acid is being oxidized, is the release of the amino group or nitrogen to make ammonia. We'll come back to that later. But the rest of the irreversible degradation is determined by the carbon backbone and what it can be made into. And you can see here that the various amino acids are shown in blue if they're ketogenic, or primarily the carbon backbone is used to make acetoacetyl-CoA, which then form ketone bodies or can go into the Krebs cycle as acetyl-CoA to be further oxidized, or the gluconeogenic amino acids, where the carbon backbone of the amino acid can be used to form oxaloacetate, and from oxaloacetate be used for gluconeogenesis. And that's an important point, because one of the problems with gluconeogenesis is that it causes the breakdown of protein to access those amino acid backbones. And that's why one of the reasons it's so critical to give glucose during treatment of children that have amino acidopathies and other and organic aciduриas, where you really want to limit the exposure to these amino acid backbones, because gluconeogenesis, whether it's caused by a lack of dietary intake of carbohydrate, or if it's caused by the provision of steroids, corticosteroids, which also stimulate gluconeogenesis. In either case, you'll get the breakdown of protein to release the substrates to make glucose through gluconeogenesis. So one of the reasons we give glucose is to avoid the need for gluconeogenesis. Just a couple of interesting facts about the amino acid content of various types of compounds. Muscle in particular does not have an equal representation of all amino acids, but the branch chain amino acids are overrepresented in muscle, with leucine accounting for 8.5% of the amino acid residues in muscle. And so when we think about the treatment of some of these diseases, you're going to get more leucine from a piece of meat than you'll get phenylalanine from a piece of meat, or methionine from a piece of meat. And so it's very important that you know the source of what the amino acid the amino acid content of the various types of dietary proteins that your patients are getting, so that you can be aware of which ones are more or less of a problem for the particular disorder that you're treating. As you all remember, there are amino acids that are non-essential that your body can synthesize, and there are those that are essential that you can only get in the diet. And of course, most of essentially all of the inborn errors of metabolism of amino acids and organic acids involve essential amino acids, ones that you only get from the diet. And the important point there is that, as you all know, is that those, you can restrict the diet in those amino acids to reduce the accumulation of toxic substrates, but you can't totally eliminate them from the diet because that's the only source of those amino acids which you need to be healthy. Again, the list of essential and non-essential is there for your reference if you want to go back. Just a little bit of math to think about what happens with protein catabolism. As you break down protein, muscle is about 20 grams of protein per 100 grams of muscle. The nitrogen content of that protein is about 16%. So essentially 1 ounce of muscle, 30 grams, is the equivalent of 1 gram of nitrogen. And 1 gram of nitrogen is 70 millimoles of elemental nitrogen, which is a lot of nitrogen for the urea cycle to handle when you're breaking down the content of 1 ounce of meat. A reminder that the amino acid composition of proteins is genetically determined. It doesn't depend on the diet. In catabolic situations where you're undergoing catabolism for the purposes of energy production, essentially all of the amino acids that are released from protein degradation are going to be oxidized for energy. You can have protein breakdown that we sometimes refer to as catabolism, also because you are deficient in one or more essential amino acids. And in that case, it's a very non-specific process. So some of the excess amino acids, even the ones you're deficient in, are going to be broken down and oxidized, while others will be available for additional protein synthesis. I left this in just to define that kwashiorkor is a deficiency of dietary protein, whereas marasmus is the combined defect of protein and calorie malnutrition. So we'll now move on to talk about the amino acidopathies, almost all of which can be identified by newborn screening, unlike the urea cycle disorders that we'll talk about at the end of this lecture. We'll begin with the hyperphenylalaninemia. Why? Because number one, they're most common, and secondly, of the amino acidopathies, and second, they are on everyone's mind because they were the very first disorder for which universal newborn screening was shown to be effective, which has had major public health impacts. I think you'll have an entire separate lecture on newborn screening later in this series. Different people use different terminology to define the hyperphenylalanemias. But I think that the three that I've listed here are in many ways the simplest way to think about it. There's classic PKU, which is the diagnosis that we apply when the phenylalanine concentration in the blood, in the plasma, without any treatment is greater than 1,200 micromoles per liter. And then mild PKU is between 600 and 1,200 micromoles. And that particular cutoff, 600 micromoles, was selected because it appears that there is below blood concentrations, persistent blood concentrations of phenylalanine below 600 micromolar do not have the same risk of brain abnormalities and brain problems as numbers higher than 600. So that's kind of a therapeutic cutoff value. And then we refer to hyperphenylalaninemia in the generic term or in the specific diagnostic term as a person who, or a condition where without any treatment, the phenylalanine in the plasma is consistently below 600 micromolars. And I'm glad to see that Nickel is on the call because he's my role model for this. But I'm just going to say to all of the medical biochem fellows out there, I don't care what terminology your dietitian uses or your attendings use or your mentors use, please use micromoles per liter when you're discussing concentrations of amino acids in the plasma, not milligrams per deciliter. That terminology is outdated. It's not standard across the world, and we need to train ourselves and our families to think about these numbers in micromoles per liter. I will not say that again. except to my own team, who I'll say it every week in our meeting, in our clinic conference. The enzyme phenylalanine hydroxylase, you can see a photograph of it here, uses tetrahydrobiopterin as a cofactor, and there are a family of hydroxylases, including tyrosine hydroxylase and tryptophan hydroxylase, that also use biopterin as a cofactor. Tyrosine hydroxylase, of course, is involved in the synthesis of dopamine, and tryptophan hydroxylase is involved in the synthesis of serotonin, two of the most important neurotransmitters for normal brain function. Phenylketonuria due to deficiency of phenylalanine hydroxylase is an autosomal recessive disorder, which you all know. The incidence is about 1 in 15 to 16,000 live births in the US, similar in Europe. Here you can see a more detailed ribbon structure of the protein, and you'll see that it's a homotetramer, which is a dimer of dimers. So here's 1 copy, 2 copies, 3 copies, 4 copies of the same protein. They form this complex structure. You can just make out the little red and blue space-filling chemical balls structures here. Those are the biopterin, and then the catalytic center is in this area of the protein. This is a protein that has allosteric activation, and what that means is that when there's a high concentration of phenylalanine, the conformation of this homotetramer changes to make it more active, and in the presence of low phenylalanine concentrations, it binds tetrahydrobiopterin more tightly, and it opens up into a less chemically active structure, which is a good form of regulation for the protein, because you don't want to keep breaking down phenylalanine if you have a low concentration of phenylalanine available for protein synthesis. So you need to have some sort of regulation of that protein to make sure that you maintain phenylalanine concentrations in the desired level in the blood and in tissues. And interestingly, BH4 stabilizes the tetramer in the lower activity conformation. The enzyme does not work without tetrahydrobiopterin, but it does stabilize it and tends to stabilize it in the lower activity conformation. There are a variety of other causes of hyperphenylalaninemia. The most common are the defects of synthesis of biopterin, and they account for 1% about of significant hyperphenylalaninemia, significant meaning identified by newborn screening. I've listed the enzymes here: GTP, cyclohydrolase, dihydropteridine reductase, and the 6-pyruvoyl tetrahydrobiopterin synthase. These are the key thing about these is that you have to rule them out, when you make a diagnosis of PKU, you have to ensure that the patient does not have one of these defects of biopterin synthesis. And the reason for that is that these defects of biopterin synthesis also affect the activity of tyrosine hydroxylase and tryptophan hydroxylase, and therefore you don't make dopamine, you don't make serotonin normally. And the treatment, therefore, is more than just dietary treatment of phenylalanine. It requires additional treatment with tetrahydrobiopterin and with DOPA. And even then, the outcomes are nowhere near as good neurologically as well-treated PKU. There is a very rare form called pterin alpha carbinolamine dehydratase deficiency that's generally very mild and may not require a lot of treatment. And then very recently, there's a new chaperone molecule been identified called DNA-JC12 that binds to all of these hydroxylases and helps stabilize them. And that, if deficiency of that, will also cause a disease that looks like the biopterin deficient form of PKU, but they have normal biopterin. So if you measure, if your clinic is in the habit of measuring the biopterin and the neoterins as the main test for biopterin synthesis, you will miss DNA-JC12. And for that reason, I strongly encourage our team to do sequencing of all patients that have PKU. It will confirm the mutations in the majority of patients that have PAH deficiency. You will identify the null mutations that are not going to be responsive to sapropterin, the BH4 analog that we use for therapy for some patients. It will confirm the diagnosis. It will give the family information about carrier status for other family members. And there you can very easily, actually probably cheaper now than getting single gene testing, you can get a panel that includes all of these genes. And so I don't think to this crowd that I need to emphasize that anymore. You guys already know this and do it. Untreated PKU, which is rarely seen anymore, but if you go to institutions for developmentally delayed adults, you'll still find some patients there that have this. Infants are typically normal for 6 to 9 months, and then around a year of age, there's slowing of the head growth. Developmental delay becomes obvious. The parents may notice an unusual odor that smells musty or like mouse urine. The child may develop seizures. And even at that point, the damage is irreversible at a year of age. And in fact, the data suggests that the treatment for PKU needs to start by the end of the first month of life to get the best outcomes. And without therapy, severe intellectual disability and behavior problems, institutionalization, and then abnormalities of the brain on MRI scan that include white matter hyperintensities that are sort of a pseudo-leukodystrophy is the term that people have used. The pathophysiology for phenylalanine toxicity is not entirely clear. It's very clear that there's an excess of phenylalanine in the blood, in every tissue, and in the brain. As many of you will recall, there are 3 different transporters for amino acids into the central nervous system, I think, and they're shared by multiple amino acids. And the one that phenylalanine uses is called the large neutral amino acid transporter. And that also transports tyrosine and tryptophan into the brain. And so one hypothesis has been that there's so much phenylalanine in the blood that it outcompetes tyrosine and tryptophan for getting into the brain, and that reduces concentrations of those neurotransmitters that come from those compounds. That may be part of it, but that's probably too simple of an explanation. And Carrie Harding's lab has shown some data that suggests that high concentrations of phenylalanine in the CNS may directly inhibit tyrosine hydroxylase and tryptophan hydroxylase. So there's more to come on that pathophysiology. It's likely to be an interesting story and may well suggest some novel approaches to therapy in the future. There's no direct pathological effect of phenylalanine that has been shown, and the livers are healthy in these children. So treatment of PKU, of clinically significant hyperphenylalaninemia with blood concentrations higher than 600 micromolar, has relied in the past primarily on dietary reduction of phenylalanine. You can't totally eliminate phenylalanine because that causes very severe protein malnutrition, but you have to limit it to a very small amount that the affected individual can tolerate. There are other treatments that have been tried. People have used giving high doses of large neutral amino acids to compete with phenylalanine at the gut level for absorption and at the brain level for uptake into the CNS, and that has been shown to have some benefit. There's chaperone therapy in the form of this tetrahydrobiopterin analog called sapropterin, also known as Kuvan. Sapropterin helps stabilize the protein and to allow it to be more active. It is only works if you have mutations that generate some PAH protein. So if you have 2 null mutations, sapropterin will not be effective. And then most recently, there's this enzyme substitution therapy. I don't call it enzyme replacement because the enzyme that's involved in pegvaliase is actually a phenylalanine ammonia lyase, which is a plant enzyme that humans don't have. So it's actually a substitution of one enzyme for another. And the important thing to remember about that is that phenylalanine ammonia lyase, the active enzyme in the enzyme substitution therapy, does not make tyrosine. So even though you get rid of excess phenylalanine, you'll still be tyrosine deficient because much of the tyrosine in your body comes from phenylalanine hydroxylation. So that's just an important reminder there. There are some experimental therapies, some manipulations of the gut biome that will try to limit absorption of phenylalanine. And then nucleotide or gene correction or replacement therapies are potentially on the horizon for this disorder. And I think this group knows a lot about that. I won't talk about that more. Do want to just circle back to the diet therapy though, because it remains the mainstay of therapy for many patients with PKU. The treatment relies on restriction of dietary protein or intact protein that contains phenylalanine, so that the daily phenylalanine content or intake is very low. And this is around 250 to 350 milligrams of phenylalanine per day is what most classical PKU patients can tolerate. That is not very much protein. There's about 50 milligrams of phenylalanine or in a gram of protein. So that's the equivalent of 5 to 7 grams of protein a day from intact protein, which is not very much. Breastfeeding is often manageable, and I think that in most centers that are practicing up-to-date metabolic care are working with families to promote breastfeeding as much as possible, while at the same time providing phenylalanine-free formula supplements to meet the rest of the protein requirements. Supplements with phenylalanine-free medical foods are available. These are foods that are made usually with elemental amino acids, with free amino acids rather than with peptides or proteins, and you can completely eliminate the offending amino acid, in this case phenylalanine. There's also products made from something called glycomacropeptide, which is a byproduct of casein production and milk processing, and this particular polypeptide is naturally very low in phenylalanine. It's not completely deficient in phenylalanine, but it's very, very low, and it has the benefit of making the foods that contain it act more like regular protein containing foods in terms of their ability for taste, flavor, cooking, and other things. So it's very well tolerated among patients with PKU. It's only useful for PKU because it does have it has many other amino acids, including branch chains in it. The diet has to be sufficient in all the vitamins, minerals, and other micronutrients. And then the special diet formula needs to be distributed through the day, because as I said earlier, there's no way to sort of store up amino acids for when you need them for protein synthesis later. You have to have them available when you need them throughout the 24-hour life cycle or diurnal cycle. And so it's very important that formulas and medical foods be distributed throughout the day in patients with PKU. And I think that everybody knows this now, but when we first started treating PKU a long time ago, we didn't necessarily think you had to be on diet for life. We thought you just had to be on diet till your brain was done developing. Back then, we thought your brain was done developing when you were 4 or 5 years old. We now realize that your brain is has not reached full maturity until the late 20s, early 30s. And that probably means that our brains never are done developing, that they probably are always changing. And that explains why diet for life is important. If you take a person with PKU whose phenylalanine in their blood is stable and in the treatment range, and you do cognitive testing, you will see a measurable difference in their IQ from when their phenylalanine is over 1,000. And that can be as high as 15 IQ points. And then what you hear from patients are, when my fees are high, I can't think, I can't balance my checkbook, I can't read the newspaper, my thinking is cloudy, I'm grumpy, my family doesn't like me. There's all kinds of issues that go along with that high phenylalanine that are hard to put your finger on a objective level, but that really make life difficult for adults with PKU. I wish I could say that it's universal, but it's not. There are adults that are highly functional, able to think clearly with blood phenylalanines of 1,500. And I don't understand why that is, but there are some patients like that. Just one quick thing about diet therapy. We already said that a gram of dietary protein contains about 50 milligrams of phenylalanine. if you work with a dietitian or an endocrinologist who has managed PKU, as was used to be somewhat more traditional than it is now, you may still encounter people who use an exchange diet. And just most of us don't use that anymore, but if you do encounter that, just be aware that one exchange for phenylalanine is 15 milligrams of Phe. I think that that's sort of a fading practice now, but still occasionally you'll come across it. Looping back to the breastfeeding, there are some strategies to be successful with breastfeeding. Again, you want to make sure that if you're breastfeeding, you have to be monitoring the Phe very carefully to make sure that you're not overdoing it with intact protein. Breast milk has a very nice amount of protein in it. It's very well suited for infants, and so it turns out to work much better in many cases than some of the cow's milk formulas that we traditionally use. So one option that some people use is just to alternate feedings. One feeding is breast, the next feeding is from a bottle with the supplemental formula. Another option that some people do is to pump the breast milk and mix it in measured quantities with the special metabolic formula at each feeding. And that has the advantage of you're giving the child, the infant, protein that they need with every feeding. And so it's a richer source. It's unfortunately not very conducive to continued breastfeeding for the family. So it works, but it's a lot of burden for the mom. And then finally, what some people have tried is to determine how much formula you need to give based on your calculations of the likely content of protein of the breast milk. Figure out how much formula to give, then divide that up among all the 8 or 7 or 9 feedings per day. Start each feeding with the metabolic formula and then let the child nurse after that. If you're going to do that, it's usually best to have them concentrate on one breast with each breastfeeding so that they get to the hind milk, which is richer in calories, lower in protein. For some babies who are especially hungry, they may take both breasts, but if you do that, you need to be aware that they're going to get a lot of more protein than you may be expecting. And so you have to, again, everything has to be titrated to the blood phenylalanine and blood tyrosine concentrations. I put this table in for reference. This is sort of the typical protein and phenylalanine intake per day. And I think one thing this is a good opportunity to discuss what happens to free amino acids in your diet. When you take a formula that has free amino acids, as most medical foods do, there's a very high rate of oxidation of those amino acids as they get to the liver. Some people have estimated that may be 20 to 40% higher than the breakdown of amino acids that are coming from protein. And it's probably entirely determined by the concentration that's coming through the portal system into the liver at any given time. The point is that if you're giving elemental formula, you have to give more protein to get the same benefit for protein synthesis in the child. And so that's why the protein suggestions here are higher than they would be if it was all intact protein. It's because it includes that 40% extra that you need to give to make up for oxidation. Monitoring the dietary therapy for PKU requires an experienced and trained dietitian. You cannot do this with a dietitian who's not familiar with PKU. You have to provide adequate calories, protein, vitamins, micronutrients, minerals. Everything has to be balanced, and we don't usually measure everything because the formulas are actually they contain pretty much everything that we're aware of that we need to treat with. The dietitians have access to programs that can allow them to calculate very precisely how much of the micronutrients a child's getting in any particular combination of dietary components. Of course, the goal of therapy is to maintain blood phenylalanine in the therapeutic range, and the recommended target range is somewhere between 100 and 350 or 360 micromolar for plasma phenylalanine. And that's, I sent out a number of references that are management guidelines for these disorders, and that is explained more fully in the PKU management guideline. that was published by the GMDI and some members of SIMD. But the goal of therapy is to keep phenylalanine in the target range and to support normal growth and neurologic development. We monitor phenylalanine frequently in the first weeks and months of life because children are growing so fast, they're either not getting enough or they're getting too much phenylalanine. So you just have to monitor frequently. As they get older, they're growing more slowly. You can start to space out the phenylalanine measurements, but we usually measure every week or two for that first 3 to 6 months of life. It's important to monitor other parameters, particularly growth and neurologic development, psychological status, bone density as kids get older because they're usually on a dairy-free diet. You have to be careful that they're getting adequate amounts of vitamin D and calcium. Iron deficiency is not unheard of, and so that needs to be monitored. Again, all the things that having a good dietitian on your team will help you remember. There are some other therapies that have been developed. We mentioned earlier sapropterin, which is a tetrahydrobiopterin analog. The goal is to enhance the, number one, to get phenylalanine in the blood into the desired target treatment range. The other goals are to enhance the Phe tolerance so that you can give more regular food, more intact protein, less special metabolic foods, and try to get a more normal diet. I think this is a good opportunity to say the dietary management for these disorders, all the ones we're going to talk about, can be very effective, but it is extremely, extremely difficult for the patients and for the families. And it's just really hard work. So anything that we can do to normalize the diet makes the family's life easier, the patient's life better, and it makes our life easier because the more intact protein the person can tolerate, the less you have to worry about whether you're giving them adequate nutrition or not. And so it's good for everybody if you can get more intact protein in the diet. For sapropterin, we usually start at a dose of 20 milligrams per kilo per day. If need be, in a person who responds but not fully responsive, you may end up going as high as 40 milligrams per kilo per day. There's a couple of different ways that you can try this. In our clinic in Cleveland, and some of my former colleagues are here, we had set up a protocol where we would, when the infant was diagnosed, we would give them a dose of sapropterin immediately and monitor the phenylalanine over the next 24 hours before starting dietary treatment to identify those infants who were biopterin deficient so that they could be treated appropriately from the very beginning. And that has been shown in studies in Europe to be a highly effective way of identifying biopterin dependence or biopterin insufficiency. It will also identify some children who are responsive to sapropterin. And so if you're able to make that work, it actually works quite well. More typically, though, is we start dietary therapy, and then later on in life, somewhere from maybe 6 months of age on, we give a therapeutic trial of sapropterin. And a therapeutic trial is usually given for a minimum of 48 hours, but usually up to a month. And the reason for that is that some kids that have PAH responsive or sapropterin responsive mutations in PAH, there may be a gradual buildup of of the enzyme activity over time. And so you may not get that 30% reduction in blood phenylalanine in the first day or the first week of treatment, but you may see it by the end of the 30 days. And then just as a reminder, you do have to have some PAH protein. You have to synthesize some protein for this to work. So if you have a null allele, the sapropterin will not work. I just put this in for reference. It's a list of mutations that are known to have just the responsiveness of some of the more common PAH mutations. There are many others that are listed, and there's several references at the biopku.org that Nenad Blau monitors or maintains. That has a more complete listing of mutations. I want to talk a little bit about pegvaliase or the phenylalanine ammonia lyase. Again, the goal is to enhance Phe tolerance. This is basically just a different way of getting rid of phenylalanine in the body. It should work for every patient. There are lots of problems with the drug. It's a daily injection. It's a protein, a foreign protein, so it causes a lot of immunologic reactions. And there are people who probably develop neutralizing antibodies or for some other reason the enzyme just doesn't work. But for most patients, with time, this drug will work if they're willing to take it. A couple things to remember: it does not reduce the need for tyrosine, so you still have to make sure they're getting adequate tyrosine, but because they often normalize their diet, that's usually not an issue. The immunologic reactions are common and have to be managed, and so you need to be prepared to deal with that either yourself or with it's very helpful to have a good immunologist if there's one available in your institution to help with that. You titrate the dose to keep the Phe in the physiologic range. And this is not necessarily the therapeutic range for PKU treatment. So we're not talking about keeping the phenylalanine at below 360 micromolar, although that's a good place to keep it. But some of these people, their Phes will drop very low, even undetectable. And so you may need to titrate the dose down a little bit because the phenylalanine's too low. The drug is not recommended during pregnancy, has not been studied, and it's only FDA approved for individuals 16 years and older, and that will probably change over time. I have to just mention maternal PKU, and as much as I would like to say this is no longer a problem, it's still a big problem. And it's a big problem because the PKU management is not easy, and a lot of adults are not really on very effective therapy right now. So women become pregnant, their phenylalanines may be 1,500 to 2,500. Phenylalanine is a teratogen, so that developing baby may well have birth defects because of the exposure to phenylalanine. The other thing to remember about treatment is that the placenta, because phenylalanine is an essential amino acid, the placenta is designed to concentrate phenylalanine on the side of the fetus. So when you measure cord blood phenylalanines, they may be twice as high as the plasma of phenylalanine in the mother. And so that's why it's critically important to get the blood phenylalanine in the mother to as low a value as you can as soon as possible, ideally before pregnancy or in the first 2 weeks after becoming pregnant, before the placental circulation is well established. But that usually doesn't happen. Usually the moms come in when they're already pregnant, their phenylalanine is high. You need to urgently get that number down, even if that requires admission to do. It's very critical that it be done. Because if you don't, the children will be born with microcephaly, heart defects are common, other birth defects are more rare, but intellectual disability is fairly common. The treatment is, as I said, aggressive therapy early, ideally before conception. Be aware that these women, that because tyrosine gets sucked out of the maternal circulation by the placenta, especially in the third trimester, they may become very tyrosine deficient. So you need to give lots of tyrosine supplements. Sapropterin, Kuvan, appears to be safe, although it's not been carefully studied. There's a lot of data accumulated over the years, and it appears to be fairly safe for use. And so the recommendation is that if a woman is stable on sapropterin, that you strongly consider continuing that during pregnancy. Pegvaliase has not been studied. We don't know yet. The recommendation is that you stop Pegvaliase and stabilize the diet and the blood Phe on diet treatment before conception. My guess is that rarely happens, and what's more likely to happen is that we're going to see women with good blood phenylalanines on Pegvaliase who come in pregnant. We're going to have to decide whether to stop it or not. And I think that many people are thinking that the risk of high phenylalanine in those women probably may possibly, if not probably, outweighs the risk to the fetus of Pegvaliase. That's a discussion you have to have with your patient on a one-to-one level and one-to-one decision making. So just to step back, there's some important things we can learn from PKU, and I won't talk about the other disorders in as much detail, but the screening and treatment can be very effective for inborn errors of metabolism. When you start doing newborn screening, you will find milder forms of the disease that may have been recognized through just clinical care. there may be unanticipated consequences of treating these diseases when people become adults, and maternal PKU is a good example of that. Treatment and intervention creates a new natural history that we don't always understand when we start therapy. And that's very true right now as all these new therapies are coming online for different disorders. Pathogenesis is more complicated than we think, and alternative therapies will continue to be developed. So with PKU finished, I'm now going to move on to a couple of other amino acidopathies, and then we'll finish up with the urea cycle disorders. Branch chain amino acid metabolism breakdown. There's the first step is to remove the amino group, this aminotransferase that works for all three of the branch chain amino acids. And then there's a common enzyme complex called branch chain ketoacid dehydrogenase that shares the E2 and the E3 subunit with several other dehydrogenases, including alpha-ketoglutarate dehydrogenase and pyruvate dehydrogenase complexes. And then the E1 alpha and E1 beta are the substrate-specific proteins that are different for each of those enzyme complexes. But this single branch chain ketoacid dehydrogenase breaks down all three of the alpha keto acids that are formed after the amino acid is removed, and then makes isovaleric acid, 2-methylbutyric acid, and isobutyryl CoA. So then these each have their own metabolic pathway in the mitochondria for further oxidation. The deficiency of branch chain ketoacid dehydrogenase is more commonly referred to as maple syrup urine disease because of the this unique odor that's apparent in the breath and the urine and the earwax of these patients that does smell a lot like maple syrup. It's kind of a sweet smell. The particular compound that causes that smell, I think, is called sotalol, and that there's some natural compounds that also contain similar ingredients and cause the same smell. In particular, a spice called fenugreek that's often used as a lactation stimulator for new moms, and is a component in some Mideastern cultures, cuisines use a lot of fenugreek. And so it's not uncommon to have a baby referred to your clinic because the family and the doctor smell maple syrup, but their amino acids are completely normal. That's usually the culprit. Maple syrup urine disease is an autosomal recessive condition. Incidence is 1 in 185,000, so relatively rare. Mutations in all 4 of the subunits have been defined, and the E2 and E3 subunits may have other things besides branch chain amino acids that are abnormal. There's a founder mutation in the Mennonite population where it's relatively common. And then the E2 subunit mutations there may be thiamine responsive, although most of the E1 alpha and beta mutations are not going to be thiamine responsive. But we typically will at least trial thiamine. There are a variety of clinical presentations. The severe neonatal form and the most biochemically affected, the kids may have the odor in the urine. They may have hypoglycemia, they may have hyperammonemia, but basically they present with a profound acidosis and are very, very ill. And if not treated promptly, they can die from cerebral edema. There is an acute intermittent form that when patients are well, when they're metabolically stable and have good homeostatic balance, they will have no or minimal elevations of leucine and the other branch chain amino acids. But when they have an intercurrent viral illness, their plasma amino acids will become very abnormal, and they develop ketoacidosis and can get very, very sick during those episodes. So those are tricky to diagnose, and if you're worried about it, the simplest thing is just to get a plasma amino acids during a febrile illness or during a vomiting illness. And then there is a subacute chronic form where, with a little bit more residual enzyme activity, where the leucines tend to run high, but they don't get that acute alpha-ketoacidosis. And those kids will develop brain abnormalities and eventually intellectual disability and spastic paraplegia if not identified and treated. And then I just want to use this time to make the point that MSUD, unlike PKU, is a true intoxication syndrome. And intoxication means that it is referring to the symptoms that occur when the brain is exposed to high concentrations of this compound. So when your brain's exposed to high concentrations of phenylalanine, it causes injury, but it doesn't cause acute symptoms. Whereas when your brain's exposed to high concentrations of leucine on an acute basis, you look drunk. You become ataxic, speech is slurred, thinking is disordered, you have increasing lethargy, progressing to coma, just like just like the same effect with alcohol or ammonia or some of the other organic acids, these intoxicating compounds. So that's what intoxication means. It doesn't mean just a toxic compound is present. It means that it causes intoxication symptoms in the brain. I'm going to skip that. Maple syrup urine disease, like most inborn errors of metabolism, you survive because your body is able to compensate using a variety of different mechanisms. So a person with an inborn error of metabolism, when they're stable, we refer to that as they're being in a compensated state. They're using every way their body can to compensate for that defect. And what that means is that they have little or no reserve capacity to tolerate increased stress. And that's what we mean when we talk about metabolic decompensation. It means that they just don't have the capacity to tolerate an increase in leucine or ammonia or whatever. And so during acute illnesses, you have to give acute treatment. And the acute treatment in MSUD is to eliminate dietary protein, to eliminate leucine primarily, which is the major toxin, but also isoleucine and valine. We need to provide adequate non-protein energy, so that's usually lipids. People start with 1 to 2 grams per kilo of intralipid during the acute phase and may even give more than that. Some people give 3 grams per kilo to start. And we give lots of sugar. This is where the idea of D10 at 1.5 times maintenance comes from. And there's nothing magical about D10 at 1.5 times maintenance. I'm not gonna, you'll hear this over and over during this series. It's about the maximum amount of dextrose you can give through a peripheral IV without burning out the vein. That's how we came on that number of 1.5 times maintenance. If you do the calculation, that much glucose provides about 50% of your daily caloric need, 50 to 55% of your daily caloric need. So it's not enough nutrition to really treat a metabolic disorder, but it does some really good things. It produces insulin, it stops gluconeogenesis, it really has many salubrious effects during the acute illness. And in a pinch, it is often adequate to reverse the acute symptoms. You want to avoid giving hypotonic fluids, and specifically you want to avoid giving glucose with very little crystalloid in it, because glucose tends to go right into the cells and the water follows, and that will cause cerebral edema. And if cerebral edema develops, that has to be treated aggressively and immediately. And dialysis can be helpful in reducing the leucine urgently if needed. I want to talk a little bit about sick day formulas that some of your clinics may use. Sick day formula generally is a special formula that the family mixes up on days when the child's ill, that has little or no intact protein in it. And I'm not aware of any well-controlled studies that have shown benefit from sick day formulas. And I just want to ask people to be careful when you use them. The data regarding utility are limited and primarily based on experience. And experience can be misleading because it's normal for all of us to, we remember more profoundly experiences that reflect our internal biases more than having a real balanced weighing of our personal experience. So you have to be careful with experience, which is the main evidence supporting the use of sick day formulas. Some of the things to be careful of if you are going to use it, families tend to overuse it and they'll do it without telling you. And so you may not be aware, and that can lead to over restriction of protein over time because the family's given the kid sick day formula 20% of the time. Also, isoleucine can become quite limiting in MSUD. It tends to drop very quickly when you start therapy. And if isoleucine gets too low, if they're deficient, they'll start to break down protein just to get isoleucine. And that will maintain the leucine at a very high concentration and can make it difficult to manage the acute illness if you're monitoring amino acids on a regular basis. The other thing is that families should not start it without talking with you. And finally, they should never use a sick day formula for more than 24 hours without specific direction from you and your nutritionist. I think we already talked about the role of carbohydrates and glucose, so I'll skip that. Chronic therapy for MSUD consists of restricting intact protein to restrict branched chain amino acids in the diet, and then providing a medical food that is depleted of branched chain amino acids. Remember that red meat in particular is very high in leucine, and so it's red meat of the proteins that are available to people is probably the one you most want to avoid in MSUD. The leucine intake is about 400 to 600 milligrams per day in kids with the severe neonatal form of MSUD. That's what most of them can tolerate, and that's really that is really a similar to the protein content of that you would tolerate with PKU as well. So it's not very much protein. Thiamine may be responsive, so it's worth trying. And then liver transplantation is very effective at reducing the circulating leucine concentrations, but it doesn't fix the problem in other tissues. So you just need to be aware of that. So there is still potential for CNS changes to occur intermittently. So now I'm going to move on to talk about tyrosine catabolism, which is after phenylalanine. And specifically, I want to talk most about tyrosinemia type 1. You can see the pathway here. I just want to point out that the compounds that are toxic are succinylacetone, fumaroacetoacetate, succinylacetone, succinylacetoacetate may be toxic. These are true toxins, but they're not intoxicating. You don't get neurologic symptoms acutely from this, but you do get long-term damage to kidney, to liver, and that can be devastating. Over time, without therapy, you develop hepatocellular carcinomas are very common later in life or later in childhood. Renal Fanconi syndrome is common. Porphyric crises occur because succinylacetone inhibits the porphobilinogen synthase that breaks down that converts aminolevulinic acid into porphobilinogen, and so this is very much like a porphyria. It's the same mechanism as one of the porphyrias. Succinylacetone also inhibits this enzyme, which is a 4-hydroxyphenylpyruvic dioxygenase, and that's the defect in type 3 tyrosinemia that we'll talk about briefly in a minute. It's also the target of action for nitisinone, the drug that treats type 1 tyrosinemia. And that just to jump ahead, the idea behind treatment is that the toxins are down here. So if you inhibit the pathway up here, you convert type 1 tyrosinemia into a much easier to treat and milder condition, type 3 tyrosinemia. NTBC, nitisinone, was originally developed as an herbicide, but it failed in its development as an herbicide because when they did rat toxicity models, all the rats got crystals of tyrosine in their eyes and they went blind. So that it was not developed as an herbicide, but somebody, once they figured out what it did, somebody had the bright idea of using it to treat tyrosinemia type 1, which is caused by fumaroacetoacetate hydrolase deficiency, FAH. Is again recessive. There's a founder effect in both northern Finland and Quebec, Canada. The Quebecois have a very high incidence of this disorder, and they've been doing newborn screening for years there. It can present in, like all inborn errors of metabolism, it can present in a variety of ways in a spectrum. These are kind of broken up into 3 classic forms: early infancy, where the kids present with severe liver disease. This has to be distinguished from lots of other severe liver presentations in early childhood. The kids that don't get severe liver disease in the first 6 months of life will often present with poor growth, and that turns out to be related to Fanconi tubulopathy or Fanconi syndrome of the kidney. And then somewhat milder forms may present with recurrent abdominal pain and severe porphyria-like attacks, and that can present at any age. We already talked about the fact that fumarate, malonyl acetoacetate, and succinylacetone are thought to be the toxic compounds. Tyrosine itself is not particularly toxic. Hepatocellular damage, including cirrhosis and carcinoma, are common, and alpha-fetoproteins remain very high in these kids without treatment and go up as they develop carcinoma. And then the tubular damage can be prevented with early intervention. Succinylacetone, we mentioned this inhibits a couple of different enzymes, including the delta ALA, or the porphobilinogen synthase, and then it inhibits an earlier enzyme. The key here is that the tyrosine really doesn't start to accumulate until you've got enough succinylacetone to inhibit that the 4-hydroxyphenylpyruvic dioxygenase. So tyrosine accumulates later in these kids and turns out to be a terrible marker for newborn screening. Totally ineffective to use tyrosine for newborn screening for type 1 tyrosinemia. You have to measure succinylacetone, which most programs do now. We talked about the treatment with NTBC. Nitisinone converts tyrosinemia type 1 into tyrosinemia type 3 chemically. And the problem there is that you then really build up tyrosine to quite high levels. So you do require dietary treatment to keep the tyrosine at an acceptable level. And this treatment markedly reduces production of the toxic compounds and markedly reduces, but does not appear to completely eliminate the risk of hepatocellular carcinoma. So we have to continue to monitor for hepatocellular carcinoma later in life. And if they develop cancer, then usually that requires a liver transplant. We start nitisinone as soon as the diagnosis is confirmed. Typically, you start with a dose of 1 milligram per kilo per day, and then you titrate up and down to get where you need to be. There are 2 ways that there are 2 targets that people use. One is to get a blood level of 40 micromoles per liter of the nitisinone. And that's because that compound at blood concentrations of 35 micromolar or higher has been shown to completely inhibit the enzyme. I think many of us, though, actually like to also monitor succinylacetone in the blood or the urine, but the blood is more precise, and see that succinylacetone is completely suppressed. And if you do that, you can actually manipulate the dose of nitisinone up and down. You can titrate to the lowest dose that works for that child to keep their succinylacetone completely suppressed. And once you figure out what that dose is, then you kind of stick with that dose as they grow. And then you continue to monitor succinylacetone, and when succinylacetone starts to creep up, then you can increase the dose of nitisinone. Nitisinone is very well tolerated. Other than causing tyrosinemia type 3, it's very well tolerated and doesn't appear to have a lot of other problems associated with it. There is some new testing of dried blood spots that will give you succinylacetone, nitisinone, tyrosine, phenylalanine all at the same time. My experience with that, though, has been that from the dried blood spots, the nitisinone concentrations are not so easy to interpret, and they're maybe less reliable than plasma. So I wouldn't use that nitisinone concentration in the dried blood spot as my only monitoring for therapeutic efficacy of the drug. Very briefly, the other tyrosinemia is type 2, which is one step above the 4-hydroxyphenylpyruvic acid dioxygenase, is tyrosine transaminase. That causes the excess tyrosine, usually when you have concentrations of 1,000 or higher, causes crystals in the cornea that are very painful. They cause photophobia, tearing, and very painful. You get plantar palmar hyperkeratosis with little pits in the palms and soles, and then intellectual disability in some cases, but not all. And that's not entirely clear why that is. That condition is also referred to as Richtner-Hanhart or Hanhart-Richtner syndrome. Type 3, very similar, can have intellectual disability and seizures if the tyrosine is not treated. And then there's the transient tyrosinemia of the newborn, which is another reason why measuring tyrosine is not such a great newborn screening tool. Most labs do use tyrosine to look for type 2 and type 3 tyrosinemia in the newborns, but many of those cases have transient tyrosinemia. The cause is unknown, but it's self-limiting. Tyrosine usually goes up over the first few weeks of life and then comes down over the next 4 to 6 weeks. So by 6 weeks of age to 8 weeks of age, the infant has normal tyrosine. Because we're screening for tyrosinemia type 1 with succinyl acetone. If succinyl acetone is normal, they don't have tyrosinemia type 1. So if tyrosine is high, then it's either type 2 or 3 tyrosinemia, or it's transient hypertyrosinemia of the newborn. The transient one, none of them require treatment in the first 2 months of life. So there's no action required for an abnormal newborn screen for high tyrosine with normal succinyl acetone, except to repeat the tyrosine at 6 weeks of age. And if it's still high at that point, then you work them up for type 2 and 3 and start treatment. But there does not appear to be any harm from not treating type 2 and type 3 tyrosinemia until the child's 2 or 3 months old. All right, so our chief, for you Monty Python fans, our chief weapon is surprise and fear, fear and surprise. Our chief weapons are fear, surprise, and a deep and abiding love for complex biochemical pathways. So now we get into methionine breakdown and homocystinuria, which is primarily due to 2 defects, one in transsulfuration, usually cystathionine beta synthase deficiency, and the other cause of homocystinuria are remethylation defects. I'm not going to talk about the remethylation defects today. I'm going to only focus on the breakdown of homocysteine into cysteine and cysteine that's due to cystathionine beta synthase deficiency. Just to remember that because the methionine is sulfur containing, the breakdown products have this sulfur group here that can form disulfides. And there's a whole list of disulfides that are formed in the body if you are accumulating homocysteine, including sulfocysteine, which is the one that most labs measure to look for defects in sulfur metabolism. Methionine is the screening tool for newborn screening for homocystinuria. And remember that you only pick up high methionine is only going to be present in the transsulfuration defects, cystathionine and beta synthase. Remethylation defects will typically not have high methionine. If anything, it will be low. Methionine will be low. And so they're not identified by newborn screening unless they also cause an elevation of propionic acid or C3 because of the involvement of some of the cofactors in the methylmalonyl-CoA mutase pathway that you'll hear more about in another lecture. Homocysteine is hard to measure. The specimen has to be deproteinized and stabilized immediately on arrival in the lab. And so it's the easiest way to do. Almost every chemistry lab in every hospital measures total homocysteine. So that's what you want to order, total homocysteine from plasma. And total homocysteine is typically over 100 in people with classical homocystinuria, up to 150. The gene we talked about, cystathionine beta synthase or CBS, again, recessive inheritance, fairly rare, 1 in 2 to 400,000. There's clearly incomplete ascertainment because cases can be missed on newborn screening. About half of cases of CBS deficiency are responsive to vitamin B6. pyridoxine responsive. And the mechanism for this, I don't know what the mechanism is. And so you just have to try it and see if they respond or not. Without treatment, you get this sort of marfanoid body habitus, tall, lean, gangly, osteoporosis, scoliosis. You see this more in the non-pyridoxine responsive forms. And then, of course, you get the ectopia lentis, eye abnormalities, and that occurs in about 90% of individuals. And for those of you who are really astute dysmorphologists in the crowd, you'll notice that I flipped the photograph of this eye upside down because I think it's actually a Marfan patient. And in Marfan disease, the dislocation of the lens usually goes up into the temporal direction. And in homocystinuria, for reasons that are not clear to me, it's most often down and toward the nose. And so I wanted to make this picture look like what you typically see in homocystinuria as opposed to Marfan. Developmental disability and neuropsych symptoms in some, but not all CBS deficient patients, rarely in the pyridoxine responsive ones who are well treated, but in the unresponsive ones, some of them go their whole life with very high homocysteines and their brain develops just fine. Others are very unusual. They can have some very unusual behavioral characteristics. Recurrent thromboembolism related to the high homocysteines is a common sign and can be a presenting sign later in life. There are lots of environmental triggers to avoid for people with hyperhomocystinuria. Atherosclerotic heart disease, common in adulthood and one of the more common causes of death, along with stroke. Thrombosis, here you can see a popliteal vein behind the knee that's occluded, and there's all kinds of collateral circulation around it. Here's a classic example of a thromboembolic stroke where you've lost brain tissue. There are lots of other causes of homocystinuria, including all of those remethylation defects that David Rosenblatt has made a career out of defining. The therapy for CBS deficiency is to try pyridoxine, to give folate, to try it. We treat everybody with folate and B12 if they're deficient. A low methionine diet. Remember that methionine is an essential amino acid and it's critical for making S-adenosine methionine, which is a very important, the most important single carbon methyl donor in the body. And so there's lots of bad things that happen if you're methionine deficient, including abnormal DNA synthesis, DNA regulation is altered. There's all kinds of bad problems. So you have to make sure methionine is adequate. You don't want to over-restrict that. Betaine or betaine, as some people refer to it as a quaternary amine that's purified from beets, Beta vulgaris. There's an enzyme in the liver that directly takes homocysteine and uses betaine as the methyl donor to reform methionine without using the B12-dependent remethylation pathway. You typically start with 50 to 100 milligrams per kilo per day. It's got a long half-life, so you can use it twice a day, works well. I've tried multiple times to spread out the doses 3 or 4 times. It doesn't make a difference in any patient I've seen. It's an enzymatically driven process, this remethylation with betaine, and so that enzyme is saturable, and we don't really know the kinetics of the enzyme very well. So it's very important as you get up to higher doses of betaine that you confirm that you're getting additional reduction of the plasma homocysteine when you increase the dose, because you will reach a point, usually it's around 200 milligrams per kilo, where you don't get any more effect by increasing the dose. All right, well, I should be stopping now, but I still have a bunch of slides about the urea cycle disorder. So I'm just gonna go through these relatively quickly. The urea cycle disorders, as you know, present with hyperammonemia. 40% present in the newborn period with lethargy, respiratory problems, hypotonia. They can have seizures. They may have poor feeding, liver dysfunctions common, including increases in AST and ALT and clotting function. Tachypnea is very common without acidosis. Later in life, they can have a wide variety of presentations with hyperammonemia, seizures, stroke, or even just neuropsychiatric symptoms, migraines in some female OTC carriers are not uncommon. Acute spastic diplegia has been reported. There's a wide variety of things that high ammonia acutely can cause. GI problems are not uncommon with recurrent vomiting, particularly hepatomegaly occasionally, particularly in some of the distal defects. And then the Rye syndrome-like episodes. And then specifically with argininosuccinic acid lyase deficiency, hair fragility, and skin rashes are common. We think about the urea cycle in two forms. There's proximal and distal urea cycle. I'll skip ahead to this example that shows this is the mitochondrial membrane, and ornithine transcarbamylase, a carbamoyl phosphate synthase, both are inside the mitochondria. So those are the intramitochondrial or the proximal part of the pathway. And then you form citrulline, which is transported out of the mitochondria. And then argininosuccinic acid synthase is and arginase are in the cytoplasm, and so those are the distal part of the pathway. You can see here that here's ammonia under being formed into carbamoyl phosphate by carbamoyl phosphate synthase. You pick up a second ammonia during the process of forming argininosuccinic acid, and that comes from aspartate, or aspartic acid, which is conjugated to citrulline to make argininosuccinic acid. And then urea is a very simple compound with one carbon and two nitrogens.
Sean, real quick, you can take your time. We've only got a couple questions on the chat, so and another 15 minutes. So you can take probably another 10, and we can have 5 minutes for questions.
Oh, great. Thank you, Pete. I appreciate that. So the proximal urea enzymes that are only in the mitochondria, only expressed in the liver and intestine and are found in the mitochondria, starts with N-acetylglutamate synthetase, and NAGS is actually a regulating. It's a enzyme that makes this compound N-acetylglutamate that turns carbamoyl phosphate synthase on and off. So your liver has a bunch of carbamoyl phosphate synthetase sitting there waiting to be activated by a protein containing meal. The protein containing meal, particularly arginine coming through the portal system, stimulates N-acetylglutamate synthase to make NAG. NAG turns on CPS and starts the urea cycle working. This is the step it can be a primary defect, but this is also the step that's inhibited by organic acids and fatty acids. And it's also a step that can be treated because there's an artificial compound called N-carbamyl glutamate that constitutively activates carbamoyl phosphate synthase. So that's the drug Carbaglu that if you are fortunate enough to be one of the 7 or 8 people in the US that have NAG synthase, it's easily treated with a drug. Unfortunately, that drug doesn't appear to work very well for any of the other disorders. Carbamoyl phosphate synthase is the first dedicated step in the urea cycle. I've included carbonic anhydrase 5A. This is a recently described carbonic anhydrase that actually makes bicarb in the mitochondria, and that bicarb pool is what is used by most of the mitochondrial carboxylases. And so that, including ornithine transcarbamylase, so you need, well, actually carbamoyl phosphate synthase combines bicarb with ammonia to make carbamoyl phosphate. And that, the bicarb is synthesized right there in the mitochondria by CAVA, by carbonic anhydrase 5A. This deficiency looks like a urea cycle disorder when they present in the early part of life, but eventually they outgrow it and they don't require as much therapy later in life. It's extremely rare, so we don't really know all the details about this yet. And then the most common is ornithine transcarbamylase that we'll talk about more. The distal blocks are argininosuccinic acid synthase, which is citrullinemia, argininosuccinic acid lyase, and arginase deficiency. Through this, just another way of looking at it, you can see that ornithine transcarbamylase makes citrulline, and citrulline is then transported out of the mitochondria by a transporter for citrulline. Citrin, which causes citrullinemia type 2, deficiency of this transporter, actually doesn't transport citrulline, it transports the aspartate, the aspartic acid, that's coming out of the mitochondria and going to be delivered to the argininosuccinic acid synthase to conjugate to citrulline. And so citrin deficiency, citrulline builds up because of a lack of a pool of aspartic acid to use for argininosuccinic acid synthase. Which is, if you're a biochemist, fascinating. If you're not, less fascinating. The relative incidence of urea cycle disorders, I've put this here. This is basically if you take a group of patients with urea cycle disorders, 55% of them are going to have OTC, 27% argininosuccinic acid synthase citrullinemia type 1, and they become more rare after that. You can use those numbers then along with newborn screening data for the distal defects, because citrulline accumulates in the cases of argininosuccinic acid lyase deficiency. So the more distal defects you can find by newborn screening, because citrulline is formed and accumulates, and citrulline is identified in the amino acid profile in newborn screening. So using newborn screening numbers along with the relative incidence of OTC to some of those more distal defects allows us to estimate the incidence of each of the 6 enzyme deficiencies of the urea cycle. And you can see here that OTC deficiency, far and away the most common. 2/3 of those are females, many of whom are completely asymptomatic, but some of whom do have symptoms. The overall incidence of urea cycle disorder is about 1 in 36,000. You all know about how to work these up, so I'm not going to belabor the blood tests that you do for a baby with encephalopathy. I do want to just remind people of this graph that Mark Batshaw and Saul Brusillo published in 1984 in the New England Journal, that kind of is the guiding light for all of our therapy for hyperammonemia in neonates, and that is looking at 26 children who presented with hyperammonemic coma in the neonatal period. The duration of the coma in days was directly correlated to the IQ score if they survived. And what this shows is that after about 4 days in a coma from hyperammonemia in the neonatal period, there is very little probability of having development to not be severely intellectually disabled as a result of that. And so typically 4 days or so of coma from hyperammonemia in a neonate who's diagnosed late is kind of the cutoff where we think about withdrawing support rather than aggressive therapy. I think that there's a lot of question about how generalizable these data are, and so these are difficult decisions to make, and this only applies to urea cycle defects and not organic acidemias, but one would presume that the toxicity of ammonia in the brain is the same no matter what the cause. Like many inborn errors of metabolism, once they get over the acute neonatal presentation, there's a relative honeymoon period where they're growing rapidly, synthesizing lots of new protein and not producing a ton of ammonia. But typically by the end of the first year, they start to have more problems. Puberty is always difficult for a variety of reasons. Menses is problematic in females, and pregnancy for females with OTC deficiency can be what pushes them over the edge. The more severe the enzyme deficiency, the more brittle the infant will be. OTC deficiency, the most common, X-linked, one of the few inborn errors of metabolism that are X-linked. There's little or no enzyme activity in males. We've already talked about the presentation. Just a couple of things. They usually don't have acidosis, and they usually don't have ketosis. The glutamine to ammonia ratio is quite high. Citrulline will be very low, arginine will be very low. Orotic acid should be apparent in the organic acid analysis, and then you do a quantitative and it will be markedly elevated. Plasma glutamine is usually quite elevated in OTC deficiency. So usually just with the amino acids, and maybe organic acids, you can get a pretty good idea that this is OTC versus an organic acidemia or fatty acid oxidation defect. Males with late onset have some residual enzyme activity. They can present in a wide variety of different ways. Some of them have brain injury, some don't. These are the cases that if we could do newborn screening, it would be very, very helpful because we could probably prevent most of the brain injuries in these people. Sometimes these are unmasked by steroids or by valproate. Steroids, again, stimulate gluconeogenesis and the breakdown of proteins to get the carbon backbone for gluconeogenesis. And every time you break down an amino acid to get the carbon backbone, you're releasing nitrogen that gets made into ammonia. Females are all over the place. Many, half to a third, will never have an overt symptom and never have a high measured ammonia. But if you do careful neuropsychiatric testing, you can often identify executive function defects in OTC carrier females, even if they've never had a high ammonia and never had a symptom. Sometimes females will present, carriers will present with, occasionally with recurrent hyperammonemia. Sometimes it's just neuropsych symptoms. They can appear to be intoxicated with ataxia, slurred speech from time to time, if they have some dietary indiscretions or if they have an acute illness. Lab testing is tricky, but orotic acid can be very helpful. You can give allopurinol because, or carbamoyl phosphate can either go into the urea cycle or it can go into pyrimidine or synthesis. And so allopurinol inhibits that pathway. And so the carbamoyl phosphate can't go into the urea cycle, can't go to pyrimidine synthesis, and so it builds up as orotic acid. So that's a diagnostic challenge that can be helpful. Unfortunately, that test is neither sensitive nor specific, and so it's easier just to do sequencing. Unfortunately, with OTC, 15 to 20% of the time, we can't find the mutation in the coding region, and it's not entirely clear whether those are non-coding mutations or whether they're just complex rearrangements that are not identified easily by existing sequencing strategies, whether there's regulatory changes or whether there are possibly other diseases that impact the function of OTC. Enzymatic testing is the hallmark, but rarely done these days. Has to be done in liver because the gene's not expressed anywhere else. If you're having a baby that's dying with hyperammonemia, please get a liver biopsy soon after death for functional testing. Just to talk very briefly about the other proximal defects, carbamoyl phosphate synthase is a relatively common, and then NAG synthase up here, which activates carbamoyl phosphate. N-acetylglutamate analog carbamoyl glutamate treats NAG deficiency, NAG synthase deficiency. It may help some kids with certain mutations in CPS1 may be responsive to N-carbamoyl glutamate as well, but you have to be careful because there's at least one reported case of a CPS1 mutation that N-carbamoyl glutamate actually made it worse. So be careful when you do that. Argininosuccinic acid synthase deficiency, citrullinemia type 1, very similar. What we found with newborn screening for citrulline is that there are actually very, very benign cases of very mild citrullinemia type 1 that don't require any treatment. So those are always hard to sort out and take a little time, but they're worth distinguishing. There's a nice publication from Europe looking at adults that they identified with this mild variant. The treatment for these conditions is all essentially the same. Citrin deficiency is totally different phenotype. I would encourage you to read about that on your own. They often don't present with hyperammonemia. They can present at any point in life. The treatment is the exact opposite of what you do for a urea cycle defect. If you've got OTC deficiency or citrullinemia type 1, you reduce protein, you give lots of glucose. You do the exact opposite for citrullinemia type 2. That is worth reading about at another time. Lyase deficiency can present with hyperammonemia. Often though presents with developmental disability and fragile hair. These kids, the parents will come in and say, my 3-year-old, I've never had to give them a haircut. That should be a very important clue. If you pull one of the hairs, you'll see these brittle regions. It's called trichorexis nodosa. That responds, that's appears to be related to arginine deficiency, and it usually gets a lot better when you put these kids on supplemental arginine. And remember, arginine, in a urea cycle defect, arginine becomes an essential amino acid because your body can't synthesize it. The other important thing about argininosuccinic acid lyase is that it's expressed ubiquitously, so it's in many, many different tissues, not just the liver, and that suggests that it has another role in the body, and that role is thought to be that arginine serves as the nitrogen donor for endothelial nitric oxide synthase, which is a very important compound at maintaining vascular tone. And the argininosuccinic acid lyase then is involved in converting citrulline back. The synthase and the lyase are involved in reforming that arginine pool that's needed for eNOS to work. And so you get abnormalities of blood pressure in these patients. Also, over time, they develop quite bad liver disease, often and sometimes in young adult life require a liver transplant. There's some evidence that suggests that that may be related to toxicity that can be reduced if you give a nitrogen scavenger to reduce the concentration of argininosuccinic acid in the tissues, but the jury's still out on that mechanism. The strategies for treatment for hyperammonemia due to urea cycle defects are all the same. Basically, it's to reduce ammonia synthesis by reducing dietary protein, removing ammonia through hemodialysis, or providing a scavenger we'll talk about more in a minute. You replace arginine to reprime whatever does work in the urea cycle. If you have an organic acidemia that's creating an inhibitor, you can try carnitine to reduce the organic acid that's inhibiting the urea cycle. Or if you're lucky, you can give carbamyl glutamate and treat the NAGS deficiency. Scavenger therapy, there's 2 main scavengers we use, benzoic acid and phenylacetic acid. The combination of the 2 is called Ammonul and can be given IV, or you can give either one orally. We no longer use phenylacetate orally. Instead, we give a prodrug which has 2 more carbons on this side chain, and that's called phenylbutyrate. Phenylbutyrate gets taken up by the mitochondria, undergoes 1 cycle of beta oxidation using MCAD as the dehydrogenase to make phenylacetate. Phenylacetate then gets conjugated to glutamine to make phenylacetylglutamine, which is easily excreted in the urine, filtered and excreted in the urine. The enzyme that does this is called phenylacetylglutamine acyltransferase. It's a very poorly characterized enzyme, so we don't know much about it other than it is saturable. So there's a maximum amount of phenylbutyrate you can use at any one time. And so it works well, but it's limited, the efficacy. Benzoic acid likewise gets conjugated to glycine to form hippuric acid. Again, note that hippuric acid only contains 1 waste nitrogen. Phenylacetylglutamine contains 2 waste nitrogens. So at least hypothetically, you get more bang for your buck from phenylbutyrate, phenylacetate, than you do from benzoate. In practice, it's not as much different as it looks like it should be on paper. I'll wrap up with arginase deficiency, which is very different, rarely presents with hyperammonemia. It can, but rarely does. But instead, you get progressive intellectual disability and spastic diplegia. And so this is the reason that we usually recommend getting a plasma amino acid when you're working a kid up for sort of generic intellectual disability, just to make sure we're not missing an arginase, because dietary treatment can be very effective. Enzyme replacement therapy is undergoing clinical trials as we speak, and there are other ways to treat this that are going to be viable to prevent the intellectual disability. They usually have massive elevations of arginine, and the enzyme is actually in red blood cells, and so it's easy to assay the enzyme in this one. I think I will not spend too much time talking about other causes of hyperammonemia that are not urea cycle defects. You'll hear about more of these in some of your other lectures later in the course. I would point out that there are some non-inborn error of metabolism causes of hyperammonemia. Valproic acid is one, although valproic acid also, that can be true if you have a POL-G deficiency, but it can also be true if you have it can unmask a urea cycle defect. And there are other cases of people with valproate who get hyperammonemia that we can't identify any specific cause. Acute liver failure, Rye syndrome, transient hyperammonemia of the newborn is a very tricky one. We don't know what causes it. It may be a transient portovenous shunt or portocable shunt where you're bypassing delivering ammonia from the gut to the liver. It's usually distinguished by very high ammonias, but the very low glutamine. So the ammonia to glutamine ratio is the exact opposite of what you see in OTC deficiency. Overgrowth of urease producing bacteria, gut flora can cause it. Portovenous or portocable shunt. So if you've got a kid with high ammonias and you can't figure out why, get an ultrasound to make sure there's not a open ductus venosus or something that's bypassing the portal blood that has the bulk of the ammonia coming from the gut, getting to where it can be detoxified in the liver. And then I just close with this sort of workup of neonatal hyperammonemia that you can tuck away and study at your leisure. So I apologize for going a little bit over. Happy to answer a few questions for those of you who can stay on, a few acknowledgements and thanks here.
Awesome. Thank you so much, Sean. That was great. We only had a couple of questions come through, so I'm glad you got to finish up. One of the questions, the only one that came from one of the fellows is from Dee Burkhardt. I don't know, Dee, if you're still on. She's a fellow at the NIH.
Yes, hi, I'm here. Do you need me to ask the question?
Yeah, if you could, that'd be great.
Thanks, Dr. McCandless. This is a great lecture. I was just curious about if we knew the mechanism for hepatocellular carcinoma and tyrosinemia.
Yeah, that's a great question. The answer is I don't know. I don't think anybody's entirely sure, but it's thought to be direct cellular toxicity related either to malleolyl acetoacetate or fumaroacetoacetate, but I don't think anybody knows. Although these days I'm hesitant to say that nobody knows because often somebody knows and it's just me that doesn't know. So, but to the best of my knowledge, it's thought to be a direct toxicity of one of those compounds.
Thank you.
Great, thank you. And then the last question, so Rob Conway had another question from Michigan about tyrosinemia type 1, 2, management. Rob, are you on?
I just have to say, I don't think it's fair to have very experienced metabolic geneticists asking questions for this fellow's lecture.
He says he's silenced. Rob, I don't know if, I don't see that I can control that. Rob's question was basically, hold on, let me scroll back up. In terms of eye crystal formation for tyrosinemia type 1, what are your targets for tyrosine levels in NTBC therapy, and when do you get worried about crystallization in the eyes?
Yeah, that's a great question. So it has been said that you don't typically see crystals if you can keep the blood tyrosine below 600. I think it's actually, I think you can tolerate slightly higher than that without getting crystallization, but I suspect that every person is different, and you kind of want to monitor that carefully. There's a real balance, and I think what sometimes we'll see is that you can sort of, if you lower the nitisinone dose a little bit, you'll still get adequate suppression of the enzyme to prevent the accumulation of succinylacetone, but you may get a little bit more flow through the system to reduce the tyrosine. So what I try to do is to titrate I try to suppress succinylacetone fully. Then I let them grow into the dose and see what's the minimum dose that you need before succinylacetone starts to go back up. And that gives you sort of a sense of what the residual activity in the system is and tells you how much you need to inhibit the enzyme earlier in the pathway to get the desired goal of full suppression of succinylacetone. And then, and presumably fumarate acetoacetate and malonyl acetoacetate stay low as well. And then that way, when you, what I find is that if you can get down to a little bit lower nitisinone dose, the tyrosine is a little bit easier to manage because the tyrosine management can be quite difficult in these kids, especially if you have to have high doses of nitisinone. But it's a great question. I think the recommended goal is under 600 micromolar for tyrosine as a baseline.
Really quickly, last question is from Laura Lacio, CBG fellow in Utah. Laura, are you on? Are you able to ask the question yourself, or would you like me to?
Hi, can you hear me?
Yep,
Yes.
perfectly.
Okay, yeah, so my question was regarding one of your comments about the transient hypertyrosinemia of the newborn is the utility of vitamin C. I know some centers recommend that for the transient hypertyrosinemia of newborns because of the potential cost being the late maturation of the parahydroxyphenylpyruvate dioxygenase, but I think it's a lot of added stress. I just wanted to know your opinion.
Yeah, thank you for asking that question. There is a little bit of data to suggest clinical efficacy of high dose vitamin C, but I've not found that to be very compelling. And I'm not convinced that this hypothesis of delayed maturation of the enzymes is real. It could be. I mean, there are enzymes that's been proven to occur, but I'm just not convinced of that. I suspect it's more likely, although again, there's data that argue against this, that there may be sort of a transient, that the ductus venosus doesn't close completely and you get a transient portocaval shunt that is contributing to that, to the transient nature. So the simple answer to your question is, I'm not convinced vitamin C makes a big difference. It's a pretty rare condition. I haven't seen it that often. The couple of times we tried vitamin C, I couldn't tell whether it made a difference or if it just got better on its own in a few days. So there's no harm in trying it. I think it actually comes down to sort of the philosophical differences between biochemical providers. Some of us feel the need to do something in every situation. Others of us feel like if I don't know what I'm doing, it's better to not do anything. And that there's no right answer. That's a philosophical question. I will say that short-term use of high-dose vitamin C seems relatively benign to me. Long-term use is more problematic because of the risk of renal stones and injury. Great question, though.
Thank you so much, Sean.
Thank you.
Yeah, thank you everybody for participating in the hangers on. There's still about 85 of you. That's fantastic. This is a much better turnout than we expected, and hopefully the lectures and the content will live up to what everybody's looking for and has today. I think Sean did a great job, and I want to thank him for that and thank him for participating. And yeah, we've got some thumbs up too. That's great. So next week is going to be Johan van Hove talking about more amino acidopathies, one specifically for the central nervous system. And stay tuned for that. And thank you all. And I'm going to be signing off here with the recording. Thank you, guys.
Thanks, everybody. Next week, we should turn on our cameras so we can get a picture of everyone. See y'all.
Bye-bye.